Ladies and gentlemen, welcome to the sixth online meeting of our foundation. The first case of coronavirus infection was seen in Hubei province in China on the 19th of November 2019. It is just over a year since the infection was recorded. On hearing the news that a suitable vaccine to control the disease will be available before the end of the year, many today feel that we will soon win the war. Although the scientists are jubilant with the results of the trial, we still have a few hurdles to cross as we do not know how long the immunity will last or even how many people can get vaccinated in a short period of time. Vaccine apart, what about the thousands who have already been exposed to the infection? We now hear about the so-called long COVID symptoms where patients can suffer multiple organ damage for months after an infection. We are informed that 500,000 Brits are struggling with lingering symptoms of COVID-19, including fatigue, breathlessness, and pain. A new research into 500 low-risk individuals revealed that the virus can have a long-standing effect on some of the major organs, including the heart, the lungs, liver, and pancreas. With this in view, I invited Dr. Sujay Chandran to talk to us today. He's a cardiologist here in Britain, and he may be able to shed some light on what this virus can do to the cardiovascular system. Sujay is the son of Dr. Subhash Chandran, a graduate from Madras Medical College and a member of our foundation. He is now a consultant at the Western Sussex Hospital and the Royal Sussex County Hospital. He is a highly trained interventional cardiologist. After obtaining his membership from the Royal College of Physicians, Sujay undertook training in cardiology through several prestigious hospitals in the UK. He then spent some time at the Norfolk and Norwich University Hospital for research to investigate the molecular mechanisms contributing to acute heart attacks. He was awarded a doctorate in medicine for his research there. Following this, he undertook subspecialty training in coronary intervention at the Royal Sussex County Hospital and the famous St. Thomas's Hospital in London. He spent a year at McMaster University in Canada, where a lot of cardiovascular trials are done. Along with other research projects, he got trained in the management of chronic total occlusions and repair of mitral valve through percutaneous mitral clip. As an interventional cardiologist, he has performed well over 1,000 procedures. Today, his areas of interest are valvular heart disease, coronary artery disease, and its investigation through intravascular ultrasound and optical coherence tomogram. He has published many papers and continues to collaborate with McMaster University with ongoing research projects. He is a member of British Cardiac Intervention Society, European Society of Cardiology, European Association of Percutaneous Cardiovascular Intervention, and the American Heart Association. I now invite Sujay to address our group.
Yeah, thank you, Uncle. Thanks for the very kind introduction. I'm by no means an expert on COVID, but I've had to learn and understand the disease as we've gone along. So I've basically summarized, and hopefully won't take longer than half an hour, what I understand by COVID and how it affects the cardiovascular system. So just a quick outline of what we'll talk about or what I'll cover. I'll look at the risk factors in terms of what cardiovascular comorbidities are associated with the worst prognosis with COVID. I will talk briefly about the pathophysiology, and then we'll move on to clinical manifestations of how it can affect the cardiovascular system. Then I'll talk about the management and treatment. And then finally, as you briefly alluded to, we'll talk about long COVID and essentially what is the long-term sequelae of COVID on the cardiovascular system and what's being done to treat that. So if we start, as you mentioned briefly, coronavirus is caused by severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2, which causes COVID-19. You're probably right in that it was the first reported case was earlier, but from what I found from literature, the first report to the WHO was actually on the 31st of December from Wuhan in China of last year. And from the WHO website from last week, we have over 53 million cases worldwide, of which there are about over 1,300,000 deaths globally. So clearly we're in a well-known international global pandemic. And essentially the symptoms are synonymous with viral infections. So the most common symptoms that we see are a dry cough, general myalgia, fatigue, as you would see with any viral illness. And according to a study by the Chinese Center for Disease Control and Prevention of over 44,000 laboratory confirmed, 10,000 clinically diagnosed, and 16,000 suspected cases of COVID-19, 81.4% exhibited mild illness, 13.9% had severe symptoms, and 4.7% were critically ill. And when I say critically ill, they're usually tachypneic or dyspneic with a respiratory rate of greater than 30 breaths per minute. Their saturations are less than 93%, and they tend to have a partial pressure of oxygen of 50% within 24 to 48 hours. And in patients with severe or critical disease, viral pneumonia can progress to acute respiratory distress syndrome and multi-system failure. And usually this is accompanied by a cytokine storm. Cytokines are part of the body's response to infection, but their sudden release in large quantities can cause multi-system failure and death. So cytokine storm is essentially a physiological response in which the innate human system causes an uncontrolled and excessive release of these pro-inflammatory molecules. So we know that COVID-19 can manifest from a pulmonary perspective. This is what we hear about in terms of acute respiratory distress syndrome and the pneumonia. Those are the symptoms that are well recognized. But in addition, COVID-19 can cause multiple deleterious effects on other organ systems. And common extrapulmonary manifestations of COVID are shown in this picture here, where essentially you can see that it causes neurological manifestations. It can affect the kidney, it can affect the liver, the GI tract, thromboembolic complications, which is something which we'll talk about later, which is very common and can cause quite significant comorbidity and mortality. Then cardiac, which is what I'm going to spend most of my time talking about today, as well as the endocrine system and the dermatological system. So there's many extrapulmonary manifestations of COVID as well. So I just want to talk briefly about the prevalence of comorbidities in hospitalized patients with severe respiratory viral infections. What we found is in hospitalized patients with COVID-19 with more severe disease, diabetes, hypertension, cardiovascular disease, which I've highlighted here in a red box, seem to be more prevalent in both the USA and China in COVID patients, similar to other significant viral illnesses from other pandemics such as MERS and influenza. And this illustrates that patients hospitalized with COVID-19 tend to have these cardiovascular risk factors. This is a picture basically and a diagram to look at myocardial injury and outcomes of patients with COVID-19. So this is data from Wuhan back from the end of January to the end of February, where they analyzed the data from a retrospective single center study looking at 187 COVID patients. And they basically found that that these patients who had underlying cardiovascular disease and an elevated troponin tended to have a higher mortality. And I'll go through this in a bit more detail. But for those who are not so familiar, troponin is a cardiac and skeletal muscle protein which is released into the blood during myocardial injury, for example, when you have a big heart attack. And they found that patients with underlying cardiovascular disease were more likely to have cardiac injury, i.e. a troponin elevation, compared with patients without cardiovascular disease. So that's 54% versus 13.2% in those patients with underlying cardiovascular disease and a raised troponin. And they also found that the in-hospital mortality was 7.6% for patients who did not have any underlying cardiovascular disease and who also had a normal troponin, i.e. this wasn't raised. However, on the graph, you can see that as you go up, so if you have with cardiovascular disease and a normal troponin, then your mortality goes up to 13%. And then eventually, when you have cardiovascular disease and a significantly elevated troponin, your mortality is that much higher at 69% or 69.44%. And these observations suggest that patients with pre-existing cardiovascular disease may not necessarily be more susceptible to contracting coronavirus or COVID-19. However, they are more prone to severe complications of COVID-19 with increased mortality. And this data suggests that myocardial biomarkers, such as troponin, should be evaluated in patients with underlying cardiovascular disease who develop COVID-19 for risk stratification, as then we can perhaps identify which patients might need early and more aggressive intervention early on. This diagram is essentially a similar study from the Chinese CDC, the Center for Disease Control and Prevention, which published the largest case series at that time to date of COVID-19 in mainland China. And they found that the overall case fatality rate was 2.3%, i.e. 1,023 deaths among the 44,672 confirmed cases. But indeed, the mortality reached 10.5% in patients with underlying cardiovascular disease. And indeed, the box that I've highlighted, these cardiovascular risk factors, showed that the odds ratios with diabetes, hypertension, and cardiovascular disease are quite markedly higher than if you don't have these comorbidities. So for example, the cardiovascular disease odds ratio is 13.64, which indicates that you're 13 times greater likelihood of CVD affecting the case fatality ratio. There is some dispute about the absolute case fatality ratio, but the point that I'm trying to underline is that patients with these risk factors tend to have a higher fatality rate. So now I'll move on to the pathophysiology of COVID-19 and how we're going to start to see how it can affect the cardiovascular system. But if we start from the left, we can see that the COVID-19 virus enters the host cell through interaction of its spike protein with the ACE2 receptor, which is the entry receptor, which you find on the surface of lots of essentially pulmonary receptors. So on the lungs, you get lots of these ACE2 receptors. And this in the presence of this cleavage protein called TMPRSS2 is what is used to prime the spike protein and allow entry of that spike protein to bind with the ACE2 receptor. Then we move on to the right and we can look at the actual effects. Moving on from, I've got 4 proposed mechanisms here, but essentially the first mechanism is a direct effect. Sorry, oh, I jumped on a slide. Sorry, so if we look at number 1, you can see how you can get a direct cytotoxic effect from the virus particle, which binds to the ACE2 receptor, and there is some basic science to suggest that just the actual binding of the virus particle to the ACE2 receptor can cause damage to the host cells. And then there are other proposed mechanisms, such as the dysregulation of the renin, aldosterone, and angiotensin-aldosterone system, where when you get dysregulation of this system, you get downregulation of the ACE2 receptor related to the viral entry, which leads to decreased cleavage of the angiotensin 1 and angiotensin 2, which results in increased inflammation, vasoconstriction, and vascular permeability, as well as tissue injury and remodeling. And if you think about this causing more inflammation and these other effects, you can see that the damage and the potential effect that this could have on an organ or a system in terms of the clinical manifestations that could arise as a result. Then you have endothelial cell damage and thromboinflammation, where the endothelial cell the virus particle attaches to the ACE2 receptor within the endothelium, and you get increased thrombin production, decreased fibrinolysis. So essentially the concept, the result of that is that you get increased thrombus formation and decreased degradation of fibrin products. So that's a very hypercoagulable state, which will lead to more clot, thrombus, and also result in some of the disease process that we're seeing. And then finally, on the right, you get dysregulated immune response, where you get depletion of T cells, inhibition of interferon signaling by the COVID-19 virus, and hyperactive innate immunity. And it's this similarly which will lead to increased production of pro-inflammatory cytokines, particularly interleukin 6 and TNF alpha. So really just to quickly summarize is that no one really fully understands the exact mechanism, but there are 4 postulated mechanisms here of how the virus may cause damage and lead to the pathology that we see. But essentially it's increased inflammation, increased clot formation, which are the main sort of proposed mechanisms for how we think this may manifest clinically. And then this diagram just shows how we can then move to understanding how it may affect the heart. So we know that greater than 7.5% of cardiac myocytes express the ACE2 receptor. It's not just the lung. So this could also explain the direct cardiac effects that we're seeing. And then you get virally driven hyperinflammation with cytokine release, which may lead to vascular inflammation, plaque instability, myocardial inflammation, a hypercoagulable state, and direct myocardial suppression. So the box in the middle shows that those sort of were just one step before the clinical manifestations, but direct cytotoxicity and some of the things that I've mentioned. So you may get hypoxemia-mediated events, supply-demand mismatch based on oxygenation levels, and then the increased inflammation as a result of cytokine storm. And also you can get disseminated intravascular coagulation, which can also mediate myocardial injury. And all of those pathophysiological mechanisms can then, we then see the effects on the heart, which I'll talk about in the next slide. But essentially, the cardiovascular manifestations include arrhythmias, where you can get atrial fibrillation, ventricular tachyarrhythmias, heart block, and thromboembolic events, where you get increased clot formation. You may see increased levels of deep vein thrombosis, pulmonary emboli. Coronary events, you see increased myocardial infarctions, increased thrombus formation, even when you don't have an occluded coronary artery. And then you may see the direct effects of the virus on the myocardium. So instead of having a myocardial infarction causing severe heart failure, you may get direct involvement where you have myocarditis and stress-induced cardiomyopathies. So I'm going to talk about all of these each in turn. So if we start with arrhythmias, this could be the first presentation of COVID-19, and new onset or progressive arrhythmia could indicate cardiac involvement. So in a study in Wuhan back in January, February, they showed that 138 hospitalized patients had 7.3% experienced palpitations as one of their presenting symptoms for COVID-19. And in the same study, new onset atrial fibrillation, heart block, and ventricular arrhythmias were also prevalent, occurring in 17% of hospitalized patients and 44% of these patients in the ICU setting. And what they also found is that, as I've talked about previously, patients with elevated troponin also had a higher incidence of malignant arrhythmia, i.e. hemodynamically unstable ventricular tachycardia or ventricular fibrillation, than those with normal troponin levels. So troponin is a really useful biomarker, particularly when patients are admitted, of trying to determine how actually unwell they potentially can be, and then trying to risk stratify and treat accordingly. And then there were results from Lombardy in Italy between February and March, which showed an increase of nearly 60% in the rate of out-of-hospital cardiac arrest during the 2020 COVID-19 pandemic, comparing to the relative similar time period in 2019, which suggests that the etiology to be either COVID-19 or other untreated pathology due to patients' reluctance to seek care. So I'm just putting up an ECG here. This was actually a 60-year-old patient when I was on call, where the ECG was handed to me by a junior doctor saying, is this patient having a heart attack? She has a history of non-Hodgkin's lymphoma, had presented with fever, and has quite an abnormal ECG. I know we said questions or comments at the end, but if anyone has an idea as to the diagnosis, I'm happy for them to unmute and just shout out.
AF.
Quite a few senior cardiologists here.
Okay, if there's no takers.
I think it's a
It is quite clearly mentioned here in all the names.
Anteroseptal subendocardial ischemia or infarction.
Yeah, I think that's a very good differential, but just remember, she has not presented with any chest pain.
It may be just ischemia.
Yeah.
Yes.
Anything else? Any other differentials?
Atrial fibrillation.
I mean, it looks like STEMI.
Yeah. So I think the obvious thing is that's why when you see this ECG, it's clearly very abnormal. And I've highlighted here where the abnormalities are seen, but this patient has got no symptoms of chest pain. Her troponin hasn't actually, I think actually wasn't even raised, but she has come in with a fever and she's COVID positive. So this ECG is very characteristic of something called Brugada syndrome, where you get coved ST segment elevation, particularly in leads V1 and V3. This is Brugada type 1. It's an inherited genetic disorder affecting this cardiac sodium channel, which can lead to life-threatening arrhythmia and sudden cardiac death. It's very rare. The worldwide prevalence is about 0.05%. But interestingly, Brugada type 1 can be unmasked by fever. And there are numerous case reports describing this in the context of patients presenting with COVID-19. So I've actually seen 2 or 3 of these in the south coast of England. You probably only see maybe 1 a year, and I've probably seen about 2 or 3 of these ECGs, which are very characteristic within a month's time period. These patients have all ended up in ITU, and it's just worth noting the management won't change in the acute setting, but long term you need to. We essentially unmasked an underlying cardiac disorder. And then they need to be on our books for risk stratification, because if they do end up having life-threatening arrhythmias, the only real treatment is to have a prophylactic defibrillator.
In the echo,
Yeah.
do you have a regional wall motion abnormality or global wall motion abnormality?
No, nothing.
Echo.
This is purely this is purely
You got a regional wall motion abnormality or global wall motion abnormality?
Yeah, so this patient had a completely normal echo. This is purely an electrical abnormality. The LV function is not in any way impaired. There's no regional wall motion abnormalities. This is purely just a very, very characteristic ECG of Brugada syndrome, which in this case is unmasked by a fever caused by COVID-19.
Alternatively, can you think of Whelan syndrome?
Yeah, I think again it depends on the case history. I think if someone had, I would never call this Brugada in the context of someone who presents with acute crashing central chest pain, and then you do a bedside echo and they have a regional wall motion abnormality. I think I just really wanted to highlight that this is just a differential diagnosis, which is quite unique to COVID-19 patients who are unmasking fevers in this group of patients, where there are quite a few case reports demonstrating this. So. And this pattern of the coved ST segments is very characteristic of Brugada. I'm just going to move on now.
Was there pericardial effusion?
She didn't have one.
Pericardial.
No, she didn't have one. She just purely had that ECG. Okay, so if we just mute
Great.
again.
You should move on. Yeah.
So now we'll move on to thromboembolic events. So patients with COVID-19, as mentioned briefly before, are at increased risk of venous thromboembolism. So we think this is because there's prolonged immobilization. It's a hypercoagulable state, as described from the pathophysiology, with increased inflammation, increased thrombus, decreased fibrinolysis, and the propensity for disseminated intravascular coagulation. So we find that patients with COVID-19 have significantly higher levels of D-dimer, the FDP products, fibrinogen, compared with healthy controls. In a French study in March of this year, 107 patients admitted to a single center ICU with COVID-19 had rates of PEs which were much notably higher than those of patients admitted to the same ICU in the corresponding year and time interval in 2019, 20.6% versus 6.1%. And subsequent studies in France and Italy have also shown high rates of thromboembolic events in critically ill patients with COVID-19, despite them having received prophylactic anticoagulation. So this is definitely one thing, and I think other physicians on this forum would also agree that I've seen lots of patients who are at increased risk of thromboembolic complications, and despite being on prophylactic fragment when they're admitted, they're still having big PEs. So you have to be very mindful, particularly if they decompensate in terms of hypoxia, where they become increasingly tachycardic. And this is where markers like troponin, BNP are quite useful as well to see if patients are getting sicker, and D-dimer. So I think there should be a low threshold for investigating if patients do decompensate, and then be treated accordingly with therapeutic doses of anticoagulation. So just moving on to coronary events, the COVID-19 virus is associated with a higher local immune response and more frequent atherosclerotic plaque ruptures and erosions, causing good-going type 1 myocardial infarctions. Adjunctive features such as hypoxemia and endothelial injury induced by the cytokine storm could play an important part in the process. But we also know that other respiratory viruses, such as influenza, are associated with more frequent myocardial infarction. And what we're seeing is that there are more thrombotic lesions, you get microthrombi, and by this, you sometimes see also that when patients who present with suspected acute myocardial infarction, they have their angiogram and you find they actually have pristine coronary arteries, but their ECG and the bedside echo will show that they have a regional wall motion abnormality, and the troponin results after they've gone to the lab are really high, but you find that there's no culprit. So often they actually have these microthrombi, and they may still be causing occlusions, but in very, very small epicardial vessels that we're not able to see. So this is quite a phenomenon that we're seeing with COVID. There's a North American COVID myocardial infarction registry called NACME, which found that there was decreased rate of acute hospitalization for good-going ST segment elevation heart attacks. This is when you have an occlusion of the heart artery causing a large myocardial infarction. And they saw a 28 to 45% reduction in the first 172 COVID patients admitted with STEMI. We saw a similar reduction in the UK in acute STEMI presentations for emergency angioplasty of 21% in the similar data that we saw with STEMI patients who had COVID. And in the North American registry, they also found that patients presenting with ST elevation were more likely to present much sicker, i.e. they were likely to have cardiogenic shock with lower LV ejection fraction, but their symptoms were more atypical as well. They weren't necessarily presenting with crushing central chest pain, but they may have ECGs which were abnormal, and also their blood pressure would be low and they'd be a lot sicker. Generally, COVID-19 patients with ST elevation had higher inpatient hospital mortality and in-hospital stroke with longer length of stay. And interestingly, also, they found that ST elevation occurred more frequently in the Black community, Hispanics, and diabetics. This is just a case which highlights the prothrombotic nature of COVID and illustrates acute stent thrombosis. I'm not sure how clearly this is seen on the images, but essentially this is a 49-year-old gentleman who presented with a lateral infarct. You can see ST elevation in leads 1 and AVL, and he was taken for emergency angioplasty based on that. And I've got the videos, but essentially you can see that this artery, which is the intermediate artery, is occluded, and it was subsequently treated, but that wasn't the end of the story, unfortunately. So this is the angiogram, and I will just highlight where the problem is, but once it's gone through the loop, but it's nice to see the video. So this is the left coronary system, the left main stem, and here you see this intermediate branch, the upper branch actually of this, which is actually giving off 2 small tributaries, but this is the intermediate artery, and this is occluded. And you can also see in the circumflex, there are a couple of lesions, one here and one here. So the operators here decided to treat the culprit, the occluded intermediate artery, and also treat the circumflex artery with balloon therapy and also stents. They actually only did balloon therapy for the intermediate because it's a small vessel. They didn't think they had big enough stents, but they used stents to treat this artery here, from here to here. And I will show you the next picture. But essentially, the premise of angioplasty is you put a wire through the stenosis, and then just inflate a balloon over that wire and re-establish flow. This was previously blocked. Now you can see that this vessel is nice and wide and open. And indeed here, the lesions that I pointed out earlier, you don't see them now. You now see nice, consistent blood flow through that vessel. And there's essentially two big stents which have been deployed here. So this we would think is now the end of the procedure. So then unfortunately, 30 minutes later, there was new onset of more intense chest pain with marked ST segment depression in the precordial leads. And what we see here is that there is still flow in this vessel, but there is the stenosis has come back, partly because there's increased thrombus, but only because they use balloons. But what you'll also appreciate here, if I can make it clear, is that where this was all very consistent, you can see an apple core type appearance here, and also here, which is actually thrombus. And essentially what's happened is 30 minutes after what should have been a routine procedure, the patient has developed acute stent thrombosis within the stented segment. And this is an optical coherence tomography of that coronary artery. And essentially it's a pullback through that vessel where you can see this is all the stent, the white silhouette that you see here, but you can see lots of thrombus, these fronds which are attached to the stent, which is not what you should see immediately 30 minutes post PCI. So this was easily fairly treated with just simple balloon expansion and also the administration of a very potent blood thinner called tirofiban, which is very effective in reducing thrombus burden. The patient did well. He was discharged on dual antiplatelet therapy. And interestingly, his initial COVID test did not was COVID negative, but antibody testing 23 days later confirmed that he was immunoglobulin G was positive for COVID-19. So this is just a case to highlight how coronary events can manifest and indeed how prothrombotic COVID can be, or COVID-19 can be. Then we'll just move on to heart failure. There's two main mechanisms of heart failure. The most common mechanism is if you have a large ischemic cardiomyopathy, i.e. you have occlusion of a coronary artery, which causes ischemia, infarction, and unfortunately then patients are left with heart failure as a result. But there is data and purported mechanisms that the virus can cause heart failure directly by cytokine release, resulting in myocardial inflammation, direct viral infection causing myocarditis. There are reports that biventricular cardiomyopathy has been reported in 7 to 33% of critically ill patients with COVID-19. And on the left, I've got just an endomyocardial biopsy of a COVID-19 patient with inflammatory infiltrates and viral particles of the virus. And then on the right-hand side, I've got a nice echo image of a patient who presented with a suspected heart attack, but actually had completely unobstructed coronaries. But what you might be able to appreciate is that this area of the left ventricular apex is not contracting as well as the rest of the ventricle is. So just this is the left ventricle, this is the left atrium, mitral valve, this is the atrial septum, this is the right atrium, and this is the right ventricle. And essentially, when you have a heart attack, it's usually the left ventricle which is grossly affected, and depends on which artery that's affected, which will then result in the regional wall motion abnormality that you'll see. So one would expect that here, because you have very little in the way of contraction at the apex, that it's an LAD infarct. But actually, this patient's coronary arteries are pristine. And this is very characteristic of something called a Takotsubo cardiomyopathy, or stress-induced cardiomyopathy, which we think is caused by rapid surge in catecholamine, where you get a sort of stunning of the apical segment of the left ventricle, which then can look like that, mimic a heart attack, but actually the long-term prognosis for this is a lot better, and simple medical therapy usually results in most of these the LV function returning to normal. So what's been reported is there are actually quite a few case reports of Takotsubo cardiomyopathy with COVID-19. So just as we kind of come to the end of the presentation, I just want to talk about some management and treatment considerations. So there's been a lot of conjecture about the use of ACE inhibitors and angiotensin receptor blockers, because the ACE2 receptor is what the virus works through. And there are a lot of patients, cardiovascular patients, diabetic, hypertensives who are on these medications. It's been intensely debated, but there's no studies thus far to support an association between the use of ACE inhibitors and angiotensin receptor blockers and the severity of COVID-19. So most European or American guidelines would suggest that you do not routinely discontinue these medications. In terms of patients who are presenting with full-blown myocardial infarctions, i.e. ST elevation myocardial infarctions, primary PCI, particularly in the UK, is the preferred option, and this is similarly in the US. It'll be interesting to see what the feeling is in countries in Asia, for example, in India, where facilities may not be so open for the entire population to have access to this. But at least in the UK and the US, it is the preferred option. But even here, we should consider thrombolysis in select cases when there may be a problem for the patient to get to a cardiac catheter lab in appropriate time and fashion, or indeed if there's no if there isn't adequate PPE. Similarly, with non-ST elevation myocardial infarctions, which are still significant events, but you don't get the characteristic pattern on the ECG, and you don't necessarily get an acute occlusion of the artery. But definitely here we would advocate that these patients should get early angiograms and revascularized quickly, if possible. So we, in my hospital, if these patients who come in with end STEMIs, we call them, we try to get them done as soon as possible so we can get them out of the hospital so they're not exposed to COVID unnecessarily, because as we've talked about, COVID and cardiovascular disease is a bad combination. I think it's important to distinguish myocardial infarction versus myocarditis. So it was talked about earlier, but echocardiography is a very useful tool for this. You can distinguish between regional wall motion abnormalities and whether this is actually just direct infiltration of the myocardium, which is quite we would expect with a viral infection, and that will also change how you manage these patients in terms of whether they need to go to the cath lab or indeed whether you just need to you can assess their LV function, determine whether how their prognosis and what their inpatient treatment might be. We need to be mindful of arrhythmia, as I mentioned before, and we need to mitigate against the risk of this. So simple things, if you see patients hospitalized, correct their electrolytes, particularly potassium, magnesium. And if you have the option to get them out of the rhythm quickly, that's great. So if they're on ITU and they have a central line, I think amiodarone is useful in this setting. Otherwise, beta blocker, digoxin, provided they're hemodynamically able to tolerate this and their renal function is okay. I've mentioned anticoagulation. This is really, really important because we're seeing a lot of it. I think all patients admitted to hospital with COVID should be prophylactically anticoagulated unless there's a contraindication. And again, there should be a low threshold to investigate for worsening sequelae of hypercoagulable states such as PE and DVT by giving them therapeutic fragmin if they're clinically deteriorating or their D-dimers are increasing. I think we've talked about the fact that troponin and BNP is a very, very useful surrogate for assessing how sick a patient can potentially be. And similarly, I think patients who've got myocardial involvement should have daily ECGs, as you may get myocarditis, pericarditis type appearances, which can be managed appropriately. And I think finally, moving on to the very sick patients, you're going to get some patients who are extremely sick in cardiogenic shock. And unfortunately, these patients tend to do badly, but in the right patient, where patient selection is critical in this instance, intra-aortic balloon pump is used, can be used as a temporary measure. And also I've seen a couple of cases of ECMO, so extracorporeal membranous oxygenation, both lung related or veno-arterial. And again, the patient selection is absolutely critical here to see whether they have a good chance of recovery. I know St Thomas's offers this, and again, their selection criteria for the patients who would most likely survive is very, very stringent. I'm not really going to talk too much about dexamethasone, but there was the landmark study Recovery, which shows in patients hospitalized with COVID-19, the use of dexamethasone, which is an oral steroid, resulted in a lower 28-day mortality among those who were receiving either invasive mechanical ventilation or oxygen alone at randomization, but not among those receiving no respiratory support. So the use of routine steroids in a cardiac setting hasn't really been demonstrated at this point. But having said that, I think in my own practice, if someone's got good going myocarditis or myopericarditis, I've started use of colchicine at a low dose, and provided that doesn't cause the patient significant side effects such as diarrhea and doesn't affect their renal function, there is some data to suggest that it reduces inflammation and can potentially reduce the size of the damage to the myocardium. And then just finally, just want to briefly talk about long COVID. Uncle Brother, you mentioned it at the beginning, but unfortunately, not everyone who acquires COVID-19 fully recovers. And patients with chronic syndrome describe a syndrome, with chronic symptoms describe a syndrome called long COVID. The NHS has now formally defined this as post-COVID syndrome, of which officially apparently there are 60,000 people in the UK. It's defined as signs and symptoms that develop during or following an infection consistent with COVID-19, which continue for more than 12 weeks and are not explained by an alternative diagnosis. That's what's called post-COVID syndrome. The condition usually presents with overlapping clusters of symptoms which may change over time and can affect any system within the body. Usually, the common symptoms are generalized pain, fatigue, persisting high temperature, and psychiatric problems. It can be categorized into 4 different syndromes: post-intensive care syndrome, post-viral fatigue syndrome, permanent organ damage, and long-term COVID syndrome. There are also reports of myocardial injury, even in the absence of thromboembolic disease and in previously fit athletes with severe disease. There's a recently preprint study called the CoverScan study, which performed serial MRI scans on a self-selected sample of middle-aged, generally healthy individuals with COVID-19, of which interestingly 70% were female and only 18% were hospitalized. The investigators found evidence of mild cardiac impairment, at least in 32%, of which 23% had mild systolic dysfunction and 11% had evidence of myocarditis. That's on MRI. And interestingly, they also found involvement in other organs, including the lungs, 33%, the kidneys and 12%, liver, pancreas, and spleen, and reported that almost 70% of individuals have impairment in one or more organs 4 months after the initial symptoms of COVID-19. So this is something that we all need to be aware of, and it's not going anywhere anytime soon. It's just an algorithm that NHSE England have proposed as a national guidelines and guidance for post-COVID syndrome assessment clinics. I'm not going to go through it in too much detail, other than to say that they've announced that they're opening 40 clinics across the country. So they are taking this very seriously, because I'm even seeing patients 3 to 4 months down the line who are presenting with quite atypical symptoms, but from a cardiac perspective, myopericarditis, pericardial effusions. And the key thing is not to dismiss these patients and to investigate their concerns very carefully. And I think primary care are going to see a lot more of this. And this is an algorithm from when COVID is diagnosed, and then the patients are reviewed at 6 weeks. And then it's determined, usually at primary care setting, using this Newcastle screening tool, which I tried to look up online, but it still hasn't been formally defined. But we'll then try and help the primary care physicians risk stratify how to and when to refer these patients to secondary care to get the appropriate input that they need. So finally, my own conclusions are that patients with cardiovascular comorbidities are more susceptible to the severe complications of COVID-19. Myocardial injury is common in COVID-19 and offers a worse prognosis. There are various cardiac manifestations that I've also talked about, and differentiation between the various causes of myocardial injury is critical for treatment and management. Management treatment strategies are important and are continually evolving. There may be a case where steroids become routine for patients who have confirmed myocarditis from COVID, but there's no evidence at the moment. And I think we need to be very aware of the long-term sequelae of the disease, with long COVID now having a formal diagnosis. But clearly, we're in potentially exciting times with the vaccine, but I still think we need to be very aware of what can happen whilst patients are inpatients, also whilst they're in the community, and also down the line, 3 to 6 months when they're still having ongoing symptoms. So that's me finished. Thank you.